Ms. Lim asked what indicators we will look at in considering lifting the circuit breaker measures. We will consider a variety of factors. First, numbers are important, but they are not the only thing. We need to be assured that community transmission locally is stemmed or very low. Community cases should ideally fall to 0 or single digit daily, with very low numbers of unlinked cases, and not just for one day, but sustained over a period of time. We also need to see a decrease in migrant worker cases. These cases are high today, partly due to proactive case finding in some settings. While we have been able to keep local community cases low, despite high number of cases among migrant workers, it is equally important to reduce the migrant worker cases over time, though it will take a while longer. Otherwise, we will continue to be at risk of a spillover from the dormitories into the wider population. Second, we need to make an assessment of the situation globally and for individual countries to inform the extent and approach on reopening our borders. We would review the rate of transmissions in other countries as well as what they have done to contain the spread. For any reopening of our borders, we are likely to start small and selectively and to continue to impose a mix of isolation and test requirements to protect ourselves from new imported cases leading to community spread. Third, we must put in place a system to allow us to open up safely. When we allow more business and social activities to resume, there will be more interactions and higher risk of virus transmission at the workplace and in the community. Therefore, we need to step up our capability and capacity to test and detect cases early, contact trace quickly, ring-fence close contacts promptly, and establish the original source of the infection to stop other undetected transmission chains, if any. These are the key enablers which will give us confidence to reopen. Let me start with the testing as the first key enabler. To date, we have conducted over 140,000 tests for COVID-19, or 2,500 tests per 100,000 people in Singapore. This is among the highest testing rates in the world. But we plan to do more and will continue to expand our testing capacity and to strategically deploy them to yield the greatest impact. Members have asked about different tests and their uses. Today, we use mainly the PCR tests to detect confirmed COVID-19 cases. The PCR works by detecting the virus RNA from a nose or throat swab and is the gold standard for detecting current infection. To the question by Ms. Lim, we use PCR testing for 3 key purposes. 1, to diagnose suspect cases, to provide early treatment and isolate close contacts. And 2, to do screening and active case finding of individuals at risk, such as migrant workers decanted from their dorms before they return to work. And 3, to do surveillance to monitor undetected cases in the community. Currently, we have the capacity to conduct more than 8,000 PCR tests a day in total across our community and migrant workers in the dormitories, up from 2,900 a day in early April. We are working with various private and public sector partners to progressively increase our testing capacity further to up to 40,000 a day. With this increase, we will widen the net that we cast for diagnostic testing for symptomatic cases, active case finding, screening, and surveillance testing in our community and among workers, including migrant workers. We will also do more testing and monitoring to pick up asymptomatic and pre-symptomatic cases among priority groups, such as nursing home residents and staff, to prevent clusters from developing. Testing is crucial as risk of infection will increase when we allow more economic and social activities to resume. Ms. Sylvia Lim and Ms. Fumiha had asked about another type of test called the serology testing. This works by detecting antibodies produced by the body to fight against the virus from a blood sample. Based on our local studies, the effectiveness of such tests is very low in the first 10 days of illness, as it takes time for the immune system to develop antibodies. Therefore, unlike the PCR testing, serology tests are useful to indicate past infection, but it is not very useful for early diagnosis because of the time lag. Many such tests in the market are also still under review and validation. Notwithstanding this, NCID has begun to use serology testing to study the level of infection among various groups, including healthcare workers, close contacts of COVID-19 patients, and the general population. Their study was published last week and found that among close to 2,000 samples from our healthcare workers, volunteers, and general population, none had antibodies pointing to a past infection. This shows that the infection rate among our healthcare workers and general population is low. The study also showed that among close contacts, around 2.5% had antibodies, despite not having had symptoms during their quarantine. That means they had been infected earlier but recovered and remained well without any symptoms. This points to the need to continue our efforts to quickly isolate close contacts of confirmed cases. We will continue to do more of these studies to help us understand the extent of spread and immunity in the community. I should add that scientific evidence of protective immunity is still under intensive study currently. There have been some suggestions to do asymptomatic testing for the entire population. We will study this. As there is no widespread community transmission here, the yield will be very low if asymptomatic testing is done indiscriminately for the whole population. To be effective, it may also need to be done repeatedly, as it does not reflect immunity, and those tested can be infected after the test. It may not be the best way to use our testing resources. Instead, we will and have started doing asymptomatic testing selectively for priority groups. For example, we currently test asymptomatic young children if they are in the same household as COVID-19 patients, since they may not be able to articulate their symptoms well. And in addition, a key priority is to protect vulnerable groups. This includes seniors, particularly nursing home residents. As mentioned, we have started to test staff and residents and at MOH and MSF homes with a high proportion of seniors, such as nursing homes and welfare homes. Such tests complement existing precautionary measures, such as good infection control practices and close monitoring for symptoms in staff and residents. They will allow us to intervene early when needed to protect the elderly residents. As more businesses reopen, we may also do more tests for essential services workers. At our borders, we can also deploy tests for arrivals to reduce the risk of local transmission from imported cases. In all, as we build up our testing capacity, we will be able to test more and for more purposes. This will be important as we start to open up so that we can preemptively detect and break any potential transmission chains. The second enabler is our contact tracing capacity. After we have confirmed a COVID-19 case, we will need to contact trace and isolate high-risk close contacts to limit the spread in the community. This needs to be done fast and it has to be scalable and thorough for it to be effective. This will allow us to quickly ring-fence and prevent further spread. We have set up 50 contact tracing teams, up from 20 since my last update in March. But we must scale up quickly if there are more cases or large clusters and to discover less obvious links. To do so manually will be very difficult. Many countries have leveraged on technology to help them contact trace effectively and efficiently. We will also explore how we can tap on safe entry and trace together, as well as other technological solutions.